So I'll tell you a little bit about myself first. I trained in urology at the university years ago, a long time ago now. And you think about urology, it's typically male-based. But as a woman in urology, I really focused on women. And then when I came out into practice, it was mostly women that showed up. So that's how my career evolved. In the early years of my career, there was an evolution of this field of medicine called female pelvic medicine or reconstructive surgery, and it's really a meld of OB-GYN and urology. And so I was able to kind of grandmother into that specialty. So that's really what I practice now. And I treat just women in my practice. We see some men every now and then, but I can speak to the male issues, but my real expertise is in women with bowel bladder elimination issues. This is really a huge step for women's health care, and we focus on women who have bowel bladder sexual issues for all etiologies, so it could be from any particular cause. We're double board certified, so meaning we kind of have a stamp of approval. We've taken the test and gone through all that approval process for both specialties, urology and FPRMS. So I work with another woman in my clinic named Mia Swartz, Dr. Swartz, and then we work very closely with pelvic floor physical therapy to help women rehabilitate whatever's gone wrong down below. So this idea of rehabilitating pelvic floor for elimination function is really what we do. And again, we work very, very closely with PT. I was talking to Amy earlier about how we need more PTs. It's a huge demand. We'll start off with usually behavioral modifications. We also do a lot of surgery for incontinence and pelvic support. And then also in-office procedures that are highly effective for helping people get things in control down below. There's a lot of collaboration in our specialty with colorectal, with GI, with neurology, with PT. So it's very much a multifaceted approach that we'll commonly use to treat whatever your issues are. For MS, we really focus on treatments and care plans to help manage bowel bladder sexual function. I'll focus mostly on the bladder today, but you can't isolate the bladder from the others. They're all interrelated. We'll call MS affected bladders neurogenic. And in urology, we'll use that term generally to say if there's anything wrong with the neurologic system, there's some neurologic cause for whatever's happening with the bladder. So it could be MS, it could be a stroke, recovery from that, Parkinson's disease, some pelvic floor injury, even after delivery, after childbirth, there might be pelvic floor trauma. All of those things can fall into that category of neurogenic. We're really seeing, these types of issues are best treated within the urology FPRMS field. That's really our specialty. Is what we do. So one of the main points I really want to emphasize is that, what's common is common. One of the big pitfalls of when a provider sees a patient and MS is on that list of problems, commonly it will get everything get blamed on MS. And so that's where we really stand back and we really try and educate our colleagues. It's like, let's just look at what's common here and offer that MS afflicted person with, all the opportunities for treatments that anybody else would get. This is where you really have to be an advocate for yourself when you're in seeing a provider, because I think a lot of docs will just say, oh, it's MS, nothing to do, go back to your neurologist. But there's a lot of things that we can do, a whole lot of things. Urinary incontinence, vaginal prolapse in women where you have laxity in the support, either vaginal, what we call, the male version of sexual dysfunction is erectile dysfunction. We joke in our clinic, vaginal dysfunction. It happens to all of us. It's just aging genitalia. And so sexuality changes for all of us as we get older. And it's really common for everyone. It happens in MS. It happens in everyone else who doesn't have MS too. So all of those treatments are highly effective, and you're all eligible for all of them. And again, I want to emphasize, if you don't bring it up, it may not get addressed. So you are your own best advocate. And in our clinics, we're very blunt in asking about, well, how do you urinate? How do you defecate? Tell us about your sexuality. And we'll get very specific about positions, whether it feels good, whether it doesn't feel good. So we can help figure out what your goals are and then help align a care plan that will address your goals. So let's talk about bladders. It's huge. It's 75% of folks with MS have some bladder control issues, some daily bother that impacts your life. There's a lot of studies looking at how bladder control or lack thereof affects every sphere of your life, from where you go, what clothes you wear, what your daily schedule looks like, how you interact with folks. It affects intimate relationships, whether you bend over to pick up your cat or whether you interact with your family, your friends, whether you exercise, how you feel about your body, self-esteem, body image is all greatly affected. There's a lot of really good studies, what we call epidemiologic studies. That's where we look at folks with a certain condition, and we say, well, what else is this associated with over time? And bladder control issues are associated with a lot of long-term chronic health issues. And sometimes they'll start off as kind of minor. You put a pad on, like, okay, I'll just get through my day. But what happens is you start to limit activities. It's associated with weight gain, with obesity, with diabetes, with heart disease, with bone fractures, with depression. So it's well recognized by all of our payers, our healthcare payers, that it's kind of a minor problem that may start out earlier in life but can develop into a much bigger problem later in life. So it merits interventions early on to keep you healthy. So bladder is a pretty simple organ. It does those two things. It stores urine and then it empties urine, hopefully on your schedule up here, controlled by the brain. There's a classic pattern for MS-affected bladders, and it's what we call disinhibited. So the bladder just kind of does his or her own thing. And that means typically when your bladder gets full, you'll get a sensory signal back up to the brain of an urge, like I have to go to the bathroom. And then there's a two-way street of information that's an inhibitory signal that goes back down to the bladder to say, wait, I'm not in the bathroom yet, hang on. But that signal never gets there with MS. And so the bladder just goes. So you get this uninhibited muscle contraction. It's a form of spasticity that's governed by the autonomic nervous system where you can have these short circuits, with MS, where you have these skipped lesions and then the communication signal just doesn't get from the brain back down to the bladder to say, wait. So that can drive this pattern of urgency and then leakage with urgency. And urge incontinence is typically large volumes. It's not just a drip, drip, drip with coughing, sneezing, activity going from sitting to standing, but it's typically large volume losses. So that can be particularly devastating because it can affect you when you least expect it. And sometimes, just a small pad isn't enough. And we're talking like depends level leakage. So that's kind of the end point. It doesn't always start at that point, but that is what it can lead to. Think about it as just another version of spasticity. The spastic bladder is what a lot of other people will call it too. You really need the intact neurologic system for that normal pelvic function. And so one of the things that we think about is we try not to isolate the bladder just alone. There's really a coordination of 3 levels that have to happen, for normal holding and emptying of the bladder. The bladder muscle, and then the urinary sphincter, which is a little further downstream, and then the pelvic floor. And Amy will talk more about pelvic floor and how PT and all that plays into elimination function. But as urologists, we really focus on bladder. And we really want to make sure that those connections between your brain and your bottom are intact. And if not, figure out kind of where that level of disconnect is, and then accommodate that treatment to address that disconnect. So if you've never seen a urologist and you've got some urinary issues and you came to see me or one of my colleagues, we would start off with just the basics. We would check a urine culture. That's the first thing. And so commonly we'll see folks that are colonized with bacteria in the bladder, and it may not present as that classic bladder infection. You may not have burning or pain. You might have intermittently cloudy urine. It might have a little bit of odor to it when you drink some fluid and it kind of clears up. But what we sometimes find is that just that colonization of bacteria can drive some of these symptoms. And so treating the bacteria alone may clear up symptoms enough. So again, think about what's common, instead of jumping right to those full-on treatments. The other thing that's really important is some sort of kidney imaging. And What we're looking for is signs of reflux or kidney stones, and this is really common. Again, sometimes, back pain, spasticity, it all gets this, ISMS, we'll treat, more baclofen or whatever, and come to find out, you've been trucking around with kidney stone for a long time. We have a low vigilance for surveying those upper tracts. Reflux is a problem where if the bladder fills and things don't always empty out, some of it might flow back up to the kidneys. And this happens in states of urine retention. It's more common in men than women because you guys have a prostate that can sometimes cork things up. And this can actually drive sort of the slow progression towards renal failure if it's not recognized. Dr. Simnad can probably speak to this better than I, but historically, like back in the 60s and 70s, when all the Vietnam vets were coming back and they had their injuries and we were trying to learn how to manage neurogenic bladders and folks with spinal cord injuries, we found there was a really high incidence of urinary infections, of kidney stones, and then ultimately renal failure. And kidney failure used to be one of the more common causes of death for folks with spinal cord injuries. So it was around that time that there were a lot of new techniques, that were developed for learning how to manage urinary tract. And that's when our real awareness, came up that, you got to manage the plumbing to keep folks healthy, who otherwise don't have an intact neurologic system. We'll commonly do cystoscopy too. And this is just a look in the bladder just to make sure there's no abnormalities that would otherwise be unexpected, a growth, a cyst, some maybe unusual way that your anatomy formed to begin with that might make it hard for you to urinate. Cystoscopy is not as rigorous as the other oscopy, colonoscopy. There's no special prep, and I tell people they can, come to their appointment and have just a quick peek in the bladder and then go home and do their usual whatever, or, go out shopping and, just carry on with your daily activities. For women, I tell them it's kind of analogous to getting a pap smear, something you wouldn't volunteer for, but, tolerable, you can get through it. So those are kind of the basis of the workup, just to make sure, the anatomy looks okay and there's no ongoing infection. And then the next test that we do, not on everybody, but, if we're trying to figure out, well, what's the next step for intervention, is a test called urodynamics. This is more provocative. And I always counsel folks, it has more potential for humiliation and pain. So, we try and set up the room so it's so embarrassing, so we can face these bladder issues kind of head on together and figure out what's going on. Urodynamics is typically done in the urology clinic. It involves a small catheter, which is like a little plastic tube. The ones that we use are about as big as a piece of spaghetti, cooked spaghetti, so it's soft. And it's a special catheter that has a pressure transducer at the end, so it can measure pressures and volumes as your bladder fills and empties. So what we're trying to estimate is what your bladder does kind of in a normal filling and emptying cycle. Now, normal, you've got some tube hanging at your bottom and somebody sitting there watching you, it's really hard because there's a lot of overlay of, how we're potty trained to, go in a private place and, eliminate. So we try and, like I say, overcome that humiliation factor so we can get some good measurements to figure out what's happening with your bladder. It takes you're in clinic a little less than an hour. That time of kind of provoking the bladder is about 10 minutes. We try really hard to make sure that you can engage in that study too and understand it. So you're not feeling like a lab rat in there and somebody poking and prodding you, but that you can actually learn something about your bladder as well. And that's so valuable as a provider to spend the time doing that, because if you understand what's happening with your bladder, then you're going to be much more likely to participate in that care plan and understand, what the benefits of that should be. Okay, so treatment options. Our real goal is to help improve storage and reduce that spasticity. So that's usually where the problem is with MS, is the bladder doesn't store. You can empty pretty well, but it won't hold much urine because the bladder muscle is spastic. So it may seem counterintuitive, but our treatments are really aimed at relaxing that bladder muscle so it can stretch and accommodate a larger volume. So you can hold more urine in between urinations. Right? We've had medications, oral medications for overactive bladder. They've been around for decades. They work as a muscle relaxant on the bladder itself. And you've probably heard of these, like oxybutynin, ditropan, Detrol, Vesicare, Myrbetriq, Centura. There's a whole class of these drugs. I have never been a big fan of these. I remember way back in residency, decades ago, just doling these things out like candy. And we would spend almost as much time managing the side effects of them as the actual benefit of the drug. So the way the drugs work is they act hopefully specifically on the bladder to relax the muscle so you can accommodate a larger volume. But they also have a lot of side effects in different parts of the body too. And they tend to have a drying effect in the colon, in the eyes, in the mouth. So dry mouth, constipation, dry eyes. Sometimes they can have some central nervous system effects with memory and a little bit with balance and steadiness. So I use these really judiciously. We'll usually use them as a trial to see if things work. And sometimes people like them. They don't have that much in the way of side effects. But usually we'll kind of move on to a therapy that has less side effects that may be more effective. And that's Botox. And Botox is a drug that's an injectable drug, and it works on muscles to help force a relaxation. It prevents the ions, the calcium ions, from transmitting in the muscle that allow you to contract that muscle. So if my hand had Botox in it, instead of going like this, I might go kind of like that. It just relaxes the muscles. And kind of depending on how much you give, my hand may not do anything, or it would just relax just enough. So the idea with bladders is we give Botox injected directly into the bladder muscle to help that muscle relax and stretch and hold a larger volume in between voids, right? So this is given typically in clinic, and I tell folks this is more than a pap smear. This is more like going to the dentist. You're not just getting your teeth cleaned; you're getting a little work done. So again, it can be uncomfortable, but it's brief. So we look in the bladder with a scope. There's a tiny little needle, and we do anywhere from about 5 to 10 injections. I'm just trying to go really quickly. And if you have MS, sometimes it doesn't matter. You may not have much sensation below the belt, and so that's pretty easy. Sometimes it can actually drive a little more spasm during the procedure, so it can be uncomfortable. But what we find is that within a couple of days, that Botox kicks in and it relaxes that muscle to the point that it's dramatic. I mean, it's really huge. So what we expect to see is a greater than 50% improvement in the leakage episodes and the number of times you're going to the bathroom. And we'll sometimes use voiding diaries to measure that. Not always. I mean, that's asking you to do a lot on your part. And what a voiding diary is to report how much you drink, how much you urinate, and we use that as a measure. So say you're urinating 20 times a day and you're drinking very little amounts and you're voiding very little amounts. Then after Botox, you expect that to be reduced to about 10 or less times a day and being able to hold about twice the volume that you were beforehand.
Would that help with retention?
No. Sure. Yeah, the question is, does Botox help with urinary retention? Not necessarily. It kind of depends on what's driving the urinary retention. So urinary retention is where you can't urinate. And this is commonly what MS folks don't have, but again, this is where we have to be really careful to say, don't blame everything on the MS, or maybe something else going on here. Urinary retention is commonly from the downstream part of the bladder control called the urinary sphincter being too tight. And sometimes you get spasticity in the urethral sphincter that's downstream from the bladder. And we will use Botox to inject at that site. It's rare. We'll see that more commonly in Parkinson's patients. And that's where we're kind of moving the Botox around the urinary tract to help figure out, well, what's spastic, what's relaxed, and, let's try and get it back in balance. But it does bring up a good question. If you Google bladder Botox, you'll see risks of urinary retention with Botox. The original studies were done in using 300 units of Botox in the bladder, and they found anywhere from a 10 to 30% risk of urinary retention where you could not urinate. And and that would usually last anywhere from about 1 to 4 weeks, and depending on which study you read. So you need to use a catheter during that time, some tube, to empty your bladder. And the Botox does wear off, and you eventually are able to get back to emptying normally without a tube. Subsequent studies have been done with 100 units and found it was just equally effective for the urgency and the overactive part, and you don't get the retention. So retention rates now are less than 5%. Most people are not symptomatic from it, meaning you're not able to empty 100% every time you do urinate, but you have a little bit left, but you're not really bothered by it. So that's how we counsel folks now about the risk of urine retention after Botox. Some of the other treatments I want to talk about is this idea of neuromodulation. Neuromodulation are treatments that act kind of like pacing signals to the nervous system that governs the bladder control. So there's two ways that we do that now. One is through a treatment, it's kind of like an acupuncture treatment, and it's actually down at the ankle. It's called the tibial nerve. So Dr. Simnad showed some cool pictures of all that innervation between here and here and here. At the very bottom of your spinal cord, your nerves come out kind of like a horsetail. And they send a fan of nerves all to the pelvic organs and all the way down your legs. There's two important nerves called the tibial nerve that go down each leg. And if you put an acupuncture needle at your ankle and put a little nerve stimulator across it, it doesn't hurt. You don't start doing this. It's just a little warmth there at the ankle. Then it will help send a pacing signal back to that sacral plexus. It actually helps calm the bladder. To be honest, we don't know exactly how it works, but it works. And there's actually been some great studies. We participated in the studies in our clinic looking at efficacy, does it work compared to sham, and then efficacy, like is it effective or not, compared to the oral medications for overactive bladder. And it works just as well as the overactive bladder oral medications. So again, that's why I'm not like a huge fan here, because we've got some of these other options that are that don't have all the side effects of the pills. The other neuromodulation strategy is called sacral nerve stimulation. It's a little more invasive. It's actually kind of like a pacemaker that goes right in the rear end back here. It's called InterStim. It's made by Medtronic. We're very cautious in how we use these strategies in folks with MS because you got to have an intact neurologic system for the buggers to work. But we don't rule it out. You know, this is always a strategy that could be used. And then this idea of urinary diversion. Last time I saw this was well over 20 years ago. We used to do some crazy surgery to reroute the urinary tract. And if somebody recommends this to you, I would strongly encourage you to get another opinion because it's rarely done these days. This is where we would basically either take out the bladder or just leave the bladder and reroute the ureters, and you'd have a urostomy, like a bag where your urine would drain out. And so we have different strategies now for managing bladders that are more effective and less disfiguring, and you don't have all the complications that could happen with the surgery. So Botox, we'll talk a little bit more about that. It was FDA approved in 2011. We were using it way before that, even before what we say off-label, because a lot of the earlier European studies and a lot of studies done here in the U.S. too just showed it's highly effective for MS. So we've done thousands of these injections in our clinic. I mentioned we can do it under local in the office. The downside is it wears off. You have to repeat injections about every 6 to 12 months. And that length of time depends on the individual. We start at 100 units with most everyone. And for some, it may last a year or more. For some, you may drop off at 3 months. And I always find it interesting, you know, it works so well as, you know, patients come back, usually that 2-week follow-up, and they're like, this is awesome, my bladder has been under control for a long time. But then when it starts to wear off, your tolerance is way down for those recurrent symptoms. You're like, I'm not going back to how it used to be. I want more of that Botox. So we schedule follow-ups at 6 months for everyone, kind of regardless of where you are. Sometimes we get a phone call before 6 months. Sometimes at 6 months we say, you know, I'll call you when I need you. But it works fabulous. It's covered by insurance too. I used to do peer-to-peer reviews and have to write some letters every once in a while, but I haven't had to do that in years. So it's covered. The other thing I want to mention is, you know, Botox works so well for spasticity in the body that I think in the neurology clinics, I know in the physiatry or sports medicine clinics, they're using it to inject in large skeletal muscles. They've got spasticity. in legs or arms or back or neck. Sometimes you're getting large dose injections in those sites too. So it's really important to, let your doctors know if you're getting Botox for any other reasons, or you're, ironing out your wrinkles too. Just because we want to make sure we don't max out that cumulative dosing that you should stay under. For emptying, we want to really help you enable this voluntary emptying, but that's not always possible. Sometimes that, even despite using Botox and getting that storage part under control, now you can store, you can't empty when you want to, or you still have the urge and you're still rushing to the bathroom and still having leaks. So one of the first things we'll do are what we call time voids, and that's going by the clock. Every 2 hours, just go. Whether you feel like you got to go or not, trying to assure that you can keep your bladder empty. And then the next thing we think about is using a catheter. And usually this is like at least 2 or 3 conversations I'll have with my MS patients. We've got the storage part under control, but they're not emptying, and so they're having maybe some overflow leakage, with the bladder relatively full, a little drip comes out, or nighttime urination is bothersome, interrupting sleep. And so a catheter is a plastic tube that you introduce into your urethra and drain your bladder, and then you take it out. So that's called intermittent catheterization or clean intermittent catheterization. I referenced, back in the 70s, all those vets in the spinal cord care units at the VA. This was really where they came about, noting that just doing an in and out catheterization cleanly, just with clean hands and a clean catheter, is sufficient, and that's safe, and that helps to get that bladder empty. You don't have to go crazy with sterilizing things, with, clean, or sterile gloves and, iodine and, boiling catheters or anything. Just having it clean is fine. The other option is an indwelling catheter, and we have a lot of patients who have indwelling catheters, and this is a tube that's left in the bladder. We change it at regular intervals, anywhere from 2 weeks to 2 months, kind of depends on the individual. It could be a catheter that comes out your urethra, and you'll hear us call it Foley. Some Dr. Foley invented these a long time ago. Or through what's called a suprapubic site. So this is right above the pubic bone, a little below the belly button, and that's placed surgically. Sometimes we'll do it under just local in our clinics, but usually we'll do it in the operating room just to make sure that we can get things secure and safe and you're really comfortable. You can really kind of personalize the management of it. So what I mean by that is, using that tube however it works best for you. So we'll give folks a plug. So if you have a catheter, whether it's coming out the urethra or the suprapubic site, you can disconnect it from a drainage bag and just put a cork in it. And if you like to go swimming, you can tuck it in your swimsuit. It makes it really convenient for intimacy as well, particularly if you have a suprapubic catheter. You can just secure it on your belly and use your genitalia however you want. That's really, really valuable for women because commonly women are started off with just a catheter in the urethra, and it's really hard to have sex when you have a catheter coming out around the vaginal area. So those are a lot of the things that we talk about in clinic. It's like, well, what exactly are your goals and how can we help you with that? And then for men, the same issues are true. Obviously, you can't have intercourse if you have a catheter coming out of your urethra. So that's where a suprapubic catheter is really valuable to just kind of get that out of the way. Your penis can be functional however you like. I'll touch briefly on bowels and sexuality, but I think we've got some other more in-depth talks on that. Constipation is really common. I talked about those overactive bladder medications. This is like the #1 side effect of constipation. So, if we're spending as much time talking about poop and pee, then we're, it's like, we got to figure out a better way to do this. Slow bowels are really pretty common for all of us as we get older, but especially common because of that autonomic dysfunction that can happen with MS. Diarrhea is on the other side of it, too, and that can be associated with infections and there's fecal impaction where you get this traffic jam of constipation, and you blow out the plug, and you get the diarrhea, and you get into these vicious cycles of constipation, diarrhea. It's not IBS, it's just an irregular bowel program. sometimes some medications and foods can be the issue. Also, fecal incontinence is a problem that can be especially mortifying, and this is something that people don't come in and say, I have fecal incontinence, how can my baby help? It usually is, I have urinary incontinence, and then we ask questions, like, oh, by the way, yeah, sometimes they lose stool too. So it's really important to address this as well. It's commonly due to poor sphincter control. That's the anal sphincter. That, you know, when you don't want to pass gas in public, you're kind of squeezing that area, doing a little kegel. That's your sphincter contracting. A weak pelvic floor, or what we call this hyperreflexic or spastic bowel. This is where we have a lot of crossover with our friends in colorectal, with GI, with PT, you know, to help make sure we've got a coordinated plan for getting all this under control. I think everyone needs a bowel program, regardless of what conditions you're living with. The basics of starting are exercise, getting up and moving, fluids and fiber, establishing a schedule, and then for folks who have some neurologic condition as well, and say, well, I don't really feel the urge, sometimes it sneaks up on me, getting scheduled, sit on the toilet at a regular time every day, regardless of whether you have urge, and, you know, give yourself at least 15 minutes. If it's longer than 15 minutes and no success, then, you know, move on with your day. But the other thing that maybe Amy will talk to them about this too is there's this widget called a Squatty Potty. You guys heard of that? It's basically when you're sitting on a toilet, having a footstool in front of you, so you're more in like the squat position as opposed to your legs kind of dangling down. I mean, now our toilets are made so high, if you're short-legged like me, your legs kind of barely touch the floor. It's really hard to relax your pelvic floor and eliminate in that. But if you can look at the furniture in your bathroom and either get yourself a little footstool, or at Bed Bath & Beyond, they have Squatty Potties. You can go purchase one, or on Amazon too. They're very, very helpful. Some of the tips, the stool's hard, you know, start with fluids and fiber, Metamucil, Benefibers, psyllium products. Some of this is trial and error. You know, not every colon is identical, so you have to work with what's going to, you know, help keep you regular. You want to drink at least a couple liters a day. That's a lot of fluid. And fiber at least 30 grams a day. If your stool's stuck in the rectum, you can feel it's like right there and it's not coming out. Suppositories, glycerin suppositories, what we call digital stimulation can stimulate a reflex for evacuation. So it may just be touching on your rear end, it may be putting a pair of gloves on and actually trying to stretch that sphincter a bit to get it to relax so your stool can come out. That's all safe, that's okay to do. And I tell folks it's like whatever it takes. Using foods to promote your motility, you know, there might be certain things that you eat. It's like, I know I will have a bowel movement with that. Prunes, high fiber, grains, that sort of thing. Stay on a regimen and allow it a few weeks to work. That's really the key with bowel programs. And so happy bowels, happy bladder, the two go hand in hand. A little bit about sexuality, and that can affect all aspects of the sexual cycle. Your sex drive, the genital sensation, the muscle tone, problems with getting an erection or ejaculation, and change in the character of your orgasm and how it feels. And then spasticity can sometimes impact what positions are really going to be possible. Really, the treatments for anyone with MS are very similar to folks without MS, too. So for women, decreased libido is very common. It's common with, you know, dealing with a chronic condition, but it's also just common with aging and change in hormones. Vaginal dryness is very, very common, particularly after menopause, so addressing these issues. What pleasures you and satisfies intimacy might change, and this is where open communication with your partner is really, really important, and sometimes counseling can be helpful to help with a mediator so you two can communicate about what actually is helpful or not. For men, same things can happen, change in libido and erectile dysfunction. So for women, you know, we really want to balance that elimination function with the sexual goals. And so that's where we talk about, you know, how are you draining your urine? You know, how are you maintaining your vaginal tissues? We treat vaginal dryness commonly with topical vaginal estrogen that can help to prevent urinary tract infections, which sometimes drive the bladder control issues. You kind of get a twofer with that one, which is a really easy therapy. For men, all the erectile dysfunction medications are safe in MS, Viagra, Cialis, and that's where you coordinate with your urologist. Interesting with erectile dysfunction, probably about 10, 15 years ago, there were some care recommendations that came out that you really should consider cardiology consults if men are having new onset erectile dysfunction. And again, you don't want to blame everything on the MS. Erectile dysfunction is a symptom of vascular disease. You know, the blood vessels that allow the penis to become erect are just not working as well. And so if those aren't working, some other small vessels in your body probably aren't working. So you have to think about the pump. So I'll just throw that out there. Penile injections are medications you can actually inject in the penis and cause an erection. They work great, almost too well, and sometimes you could overdo it. And I know you heard the word priapism, where you get an erection that doesn't come down. Actually, you probably heard about it in 6 o'clock news on some Squatty commercials. But yeah, I thought, nobody's ever heard that word before. Now it's like out there. But you have to be careful with them. And again, you want to be under the care of somebody who knows what they're doing and making good recommendations. Penile prosthesis is like on-demand erections. These things are amazing, it's a lot to go through. I remember I made it through surgery residency without ever fainting in the OR, and that was the very first case where I thought, oh my God, I can't believe what these guys go through for an erection. And it really gave me a great appreciation for how important sexuality is for our idea of our body image and who we are as a person. And so it is a lot to go through. It's a surgery where basically a balloon-like device is implanted into the penis, and there's a little button in the scrotum that you can, pump it up or take it down. So it is an on-demand erection. But for men that can't get an erection but still have an innervation for ejaculation, this works great, because you can have an erection to have enough stimulation to have an erection. So it's very common in diabetes where you'll see the vascular disease, leading to the point where a prosthesis would be indicated, but also in MS too. So I wouldn't rule it out. And this is something that you definitely want to go to a specialist that does a lot of these. And we have a couple guys here that work in our group that do. All right, so the one thing I haven't really talked about is pelvic floor, and thankfully we've got a whole lecture on it. This is a very, very important part of elimination function. This is a bottoms-up picture of a woman's pelvis, and you can see there's about 14 paired muscles, superficial and deep, that really help to govern elimination function. So I'm not going to steal Amy's thunder, but I just wanted to say this is a huge part of elimination function that I didn't touch on. Pelvic floor PT, biofeedback, and MS can be very, very helpful. Again, we're going to have a lecture on it, so I don't want to go on with that. I want to thank you for paying attention. If you wanted to contact our clinic, here we go.